Now we're going to move on to a little bit of a different topic. We've been talking a lot about bleeding, but what happens when our patients aren't bleeding, but they need to stop anticoagulation because they have a procedure that's coming up? And that's where Dr. Umberto Campia, one of our colleagues in vascular medicine, is going to tell us how we navigate this.
Thank you so much. Thank you, everybody, for attending this program. And we can move on. I have no conflict of interest to report, and I will not discuss any off-label or investigational use of any agents. And at the end of this lecture, we should be able to discuss the balance of bleeding and thrombotic risks in patients who are on anticoagulation and require an invasive or surgical procedure. Also, we will see how to categorize the procedure and patient-related variables that are affecting the periprocedural bleeding and thrombotic risk. And finally, we should be able to describe the perioperative management of patients who are receiving oral anticoagulants and that are planned to undergo elective procedures. And we will look at the timing of interruption, indication for bridging, and restarting of anticoagulation. It is, I think, a common experience for most clinical practitioners that patients who are on chronic oral anticoagulation need at some point some form of invasive procedure or surgery. And this relatively recent paper shows that about 10% of patients on chronic anticoagulation require surgery or an invasive procedure each year. Now, the management of patients who are on anticoagulations but require an invasive or surgical procedure is challenging. And why is that? Because we have really two competing considerations. The first one is that anticoagulant therapy increases the risk of bleeding that is associated with the procedure. But at the same time, holding anticoagulation for a procedure transiently increases the risk of thromboembolism, of the occurrence or recurrence of a thromboembolic event. Now, this picture shows in a sort of a graphic way the competing risks that we can have. If we look at the anticoagulation holding time prior to the procedure or even after the procedure, the shorter is the holding time, and obviously we will have a higher risk of bleeding. At the same time, if we want to avoid the risk of bleeding and we hold the anticoagulation for a longer time, we incur in an increase in the thrombotic risk. So our challenge is to find this optimal window of time when we can reduce the risk of bleeding without increasing excessively the risk of thromboembolic events. And so we need to do, when we assess a patient who is planned to have a procedure and is on an anticoagulation, we need to keep these competing risks into account. But we also have to keep in mind that each anticoagulant has specific features that will need to be taken into consideration for our decision making. And the bleeding risk also and the thrombotic risk may vary depending on individual circumstances. And unfortunately, evidence-based data often are not available to guide our practice and to tell us when to stop and how to stop and when to resume. Now, we have to keep in mind, though, that we may have different temporal necessity of a procedure. We may have an elective procedure in which we have really the luxury of time. We can schedule the procedure in advance, we can prepare for the procedure, we can include our sort of described anticoagulation management, and we are not in a rush. However, there are procedures that are time sensitive, so we may not have the same time window to prepare. Procedure that may be urgent or emergent, in which really we have no time to prepare. for my talk, I will just focus on the elective procedures. And for the non-elective procedures, particularly with regards to the urgent and the emergent procedures, what Dr. Connors mentioned earlier, the use of some approaches that are common sense, and also the use of some of the newer agents to reverse anticoagulation may be considered. Now, when we have to estimate the risk of holding anticoagulation, we have to consider what is the indication for the anticoagulation. And the most common condition that increase the risk of thromboembolic events while holding anticoagulations are obviously atrial fibrillation, a recent, usually considered within the last 3 months, venous or arterial thromboembolic event, and the presence of prosthetic heart valves, particularly when we consider mechanical heart valves. And when we look at this sort of summary table, we can see that based on what indication for anticoagulation, whether it's a mechanical valve, atrial fibrillation, or thromboembolic event, we can stratify risk as a very high thrombotic risk, as a high thrombotic risk, or as a moderate thrombotic risk. And we can see that the presence of any mitral valve or any old valves, we still can see patients that have cage ball valves or tilting disc valves. They become less and less frequent though. And then recent stroke or TIA, these are all very high thrombotic risk. The newer generation valves, the bileaflet prosthesis, or the presence of atrial fibrillation with the previous stroke, hypertension, diabetes, or other risk factors such as age, confer a high thrombotic risk. And the moderate thrombotic risk for the valves are the more recent bileaflet valves without any other risk factors for a thromboembolic event. For the atrial fibrillation, the CHA2DS2-VASc score, obviously the higher the CHA2DS2-VASc score, the higher the breathing risk, the occurrence of recent thromboembolic events, and the presence of rheumatic valvular heart disease, which in and of itself is a high thrombotic condition. If we have sort of intermediate risks, intermediate CHA2DS2-VASc score, we are at a high thrombotic risk. And when we have low CHA2DS2-VASc scores, we have a moderate thrombotic risk. The same for the VTE, with the recent occurrence of a thromboembolic event, the presence of a severe thrombophilia, such as deficit of protein C, protein S, or antithrombin, or the presence of antiphospholipid antibodies, or the presence of multiple abnormalities is a very high thrombotic risk. Then intermediate risk is a recent but not within the last 3 months venous thromboembolic event, a non-severe thrombophilia, the more common such as heterozygous factor V Leiden or prothrombin gene mutation, or active cancers. And if we have a older occurrence of a venous thromboembolic event without other risk factors, we are in probably the presence of moderate thrombotic risk. Now, when we consider the bleeding risk, we can classify based on the type of surgery or procedure that we are going to have. If we have if we have a procedure that has a relatively low bleeding risk, many times we do not have to discontinue anticoagulation. So if we have an extraction of 1 to 3 teeth, periodontal surgery, an incision of an abscess, an implant positioning, or a ophthalmic surgery with cataract, endoscopic surgery without biopsy, or a superficial surgery, or a urologic surgery with a double J stent insertion, we can discontinue anticoagulation. In some cases, we can, particularly with a Coumadin, we can decide to have a lower INR range that we can use. Also, and I use this relatively frequently in patients who have a dental extraction or need sort of a more dental cleaning, I give a prescription for a mouthwash for tranexamic acid. and that can help to reduce the bleeding risk. And it is a very simple treatment, and many times patients are not aware of this opportunity, and also physicians may not be aware. When we have instead procedures that are associated with a sort of higher bleeding risk that is not negligible, we may consider holding the anticoagulation, and this would be endoscopy with biopsy, prostate or bladder biopsy, angiography, electrophysiologic study, or pacemaker implantation. This would be in a relatively straightforward anatomy, but not if we have a more complex, such as a congenital heart disease. Now, procedures that have a high bleeding risk that require mandatory holding of the anticoagulation are procedures such as neuraxial anesthesia, in intracranial surgery, cardiothoracic surgery, major abdominal gynecologic surgery, orthopedic surgery, and we can see also other procedures that may be urological without being major surgery. Now, once we determine that the patient needs to have an anticoagulation interruption, we should determine when we should interrupt. So, prior to procedure with a high or moderate bleeding risk, anticoagulation should be stopped early enough to allow hemostasis to normalize. Obviously, if we have a patient on a vitamin K antagonist, we can clearly, easily measure the termination of the resolution of the effect, and we can use just the prothrombin time and then the INR. However, this may not be available. These measurements are not available as a standard measurements for patients who are on the direct oral anticoagulation. Now, as Dr. Knall was mentioning earlier, having an approach that is a sort of a stepwise in a more algorithmic fashion, I think really helps. And luckily, recently, we have had this additional expert consensus document that has given us some guidelines with regard to interruption, and this is in patients with atrial fibrillation, but the concept apply to patients also who are on anticoagulation for other indication. Now, the main concepts are the ones that we have mentioned earlier. Assess the bleeding risk associated with the patient, and then the procedural bleeding risk. So if the patient has a bleeding risk that is elevated, the presence of major bleed or intracranial bleed in the recent 3 months, platelet abnormalities such as the use of aspirin or other antiplatelets. Patients may be on a P2Y12 inhibitor as well. And the presence of an INR that has been above the therapeutic range prior to the interruption, or a previous bleeding during a bridging or similar procedure. And so if the patient does not have any of this, then we consider the procedural bleeding risk. And if the procedural bleeding risk is considered non-important or low, we should perform the procedure uninterrupted. However, if the patient has an intermediate or high risk, we should go through the pathway for an interruption. If we have an uncertain bleeding risk with regards to the procedures, this is a recommendation, and I tend to follow very frequently. Talk with the proceduralist. Ask the colleague who's doing the procedure, what do you think this risk is going to be? And I tend to exceed on the rate of bothering my colleague and ask, do you think that this is going to be a high risk of bleeding? Should I be very aggressive in holding anticoagulation? And then the clinical judgment is obviously something that we should always use. And many times I ask more experienced colleagues. Now, once we instead consider that the patient has a higher bleeding risk, and then I assess the procedural bleeding risk, then interruption is probably the way to go. And we should always keep in mind that the bleeding risk in these patients may be elevated, and we may be at risk of underestimating it. Now, once we have decided that the interruption is necessary, we should say when should we interrupt. And if a patient is on a vitamin K inhibitor, we should consider measuring the INR 5-7 days prior to the procedures. If it is supratherapeutic, we should have a longer discontinuation time, and then we may recheck the INR 24 hours before the procedure. And this is a practice that I always do, and if the INR is still elevated, I consider using some vitamin K to complete sort of the reversal. If we have that the INR is within the goal, I discontinue within 5 days, and I still consider, and I do most of the time, an INR 24 hours prior to the procedures. If the INR is subtherapeutic, I may consider a shorter period of time and again recheck the INR. And once we have the established timing, we should consider the bridging. Should this patient be bridged while we hold the anticoagulation with the vitamin K? And in this case, obviously the bridging relates to the thrombotic risk. And the concept that we have examined before apply also to this algorithm. First of all, we bridge for patients who are on a vitamin K antagonist. We do not need to bridge the novel or anticoagulant, the direct or anticoagulant, because they have a much shorter half-life. And with regards to the thrombotic risk, if the thrombotic risk is high, and this is such as a high thrombotic event that has occurred in the previous 3 months, I would consider delaying the procedures. Many times patients are undergoing elective procedures, and the procedure can be delayed without major risk. Sometimes patients, however, may have cancer, and you really have to balance the two competing risks. Delaying surgery that may be life-saving for cancer, or delaying or undergoing surgery with an increased risk of bleeding. With regards to patients who are at bleeding risk, there is a high, we can consider bridging. If we have a patient that has a high bleeding risk, but does, high thrombotic risk, but doesn't have an increased bleeding risk, definitely bridging is the way to go. But if we have a patient that has a low bleeding, a low thrombotic risk, there is no indication for bridging. In this sort of intermediate range, we need to use our judgment. Is the bleeding risk outweighing the thrombotic risk or not? And we may have to use more our previous experience rather than necessarily any evidence to guide us. Now, here this table is just a summary of the bridging recommendation that for the different indications, atrial fibrillation, recent thromboembolic events, whether venous or arterial, and the occurrence of mechanical valves. We can see here that the ACCP guidelines do have recommendation regarding the bridging. However, the AHA, ACC, and Heart Rhythm Society guidelines do not have. And we could always keep this consideration in mind whether to use a bridging or not. Now, how do we bridge? It's very simply based on the concept that have been outlined earlier by my colleagues, is we use usually a short-acting agent, low molecular weight heparin or a unfractionated heparin, and we consider kidney function. And based on the normal or reduced kidney function, we may use unfractionated heparin, low molecular weight heparin. Dosing can be adjusted based on the low molecular, based on the eGFR that is measured. Now, if we have a patient that is also at a high risk of stroke, but also the increased bleeding risk, we have again to use our judgment. And determine whether the risk of bleeding outweighs the benefit of the bridging. Now, when we use DOACs, now we are going to use the same concept that we have outlined earlier. We consider the bleeding risk and we consider the procedural risks. And once we decide that we are going to interrupt anticoagulation, we will base the timing on the creatinine clearance. And we can see here that there are different timings based on the levels of creatinine clearance. And the concept is that these agents may require a longer or may have a longer half-life based on creatinine clearance, and then we will need to hold them for a longer period of time prior to anticoagulation. And again, we do not need to bridge in the patients who are on NOACs because of the usually short half-life. Now, how do we restart? Again, it is a matter of matching, of competing risks. We would have, if we start too early, we will have an increased risk of bleeding. If we delay too much, we may incur an increased risk of thrombotic events. I tend to consider the type of procedure and discuss with the proceduralist when they feel that the anticoagulation can be resumed, and if the procedure is associated with a high risk of bleeding, I tend to delay 48, 72 hours. If the risk of bleeding is low, I tend to consider at least 24 hours. And one consideration is possibly use a lower dose as a first dose, and then move to the higher dose. And obviously, anticoagulation would have to be considered as a long-term, but many times patients may have a longer period of time in which there is contraindication to anticoagulation, particularly patients who have undergone brain surgery. And in this case, my approach is to continue a very close communication with the neurosurgeon or the surgeon that has performed the procedure to have a better sense of when the bleeding risk is low enough that anticoagulation can be restarted. And sometimes it's better to have a prophylactic dose anticoagulation that is not fully covering but allows some protection with an acceptable bleeding risk than try to start at a full dose and then have a high risk of bleeding that would be at times catastrophic. And with this, I am completed, and we will have questions later on. Thanks.
Very good. Thank you, Umberto. Thank you very much.